Welcome back, everyone. If you're a biology student or gearing up for a career in healthcare, today's explainer is absolutely for you. We are going on an incredible top-down anatomical tour of pathogens. We're going to map out exactly how these microscopic invaders conquer human biology, starting right at the surface of the eyes and traveling all the way down into the deep, normally sterile tissues of the lungs. Today is all about defining the essential terminology and recognizing the common clinical presentations you actually need to know. Okay, here's our roadmap for today. We'll start with ocular infections, move down to ear and sinus pathogens, tackle the upper respiratory tract, examine viral and fungal invaders, and wrap it all up with the spectrum of pneumonia. Section 1. Ocular infections and presentations. Let's kick things off right at the top of the head. Let's ground ourselves in the anatomy first. Look at how exposed the conjunctiva and the cornea literally are to the outside world. I mean, normally, our tears do a massive amount of heavy lifting here, washing the eye with natural antimicrobial fluids to keep things relatively sterile, but opportunistic bacteria and supercontagious viruses have actually evolved specific mechanisms to bypass these defenses and trigger intense, localized inflammation. Now, you definitely know the most common clinical presentation of this, conjunctivitis, or good old pink eye. But for us, the absolutely crucial point is knowing how to clinically distinguish the underlying cause. Is it bacterial? Well, that's often from trauma or maybe leaving your contacts in way too long, and it typically produces this really thick, white, pus-like discharge, usually from bugs like Staphylococcus aureus or Pseudomonas aeruginosa. But if it's a highly contagious viral form, you're usually looking at a clear, watery fluid instead. Now take a look at this. This is a much more severe, systemic presentation called neonatal gonorrheal ophthalmia. This happens when a neonate picks up Neisseria gonorrhea while passing through an infected birth canal. Just look at the marked erythema. It is intensely red and inflamed. If this isn't hit immediately with targeted antibiotics, you're looking at deep corneal ulcerations and, tragically, ultimate blindness. But hey, pathogens aren't the only threat to eye tissue, right? Sometimes our own immune systems can trigger devastating conditions. Let's define Stevens-Johnson syndrome. This is an idiosyncratic, delayed hypersensitivity reaction. It goes after mucous membranes incredibly aggressively. And while its exact etiology is often idiopathic, meaning we don't really know the exact cause, it severely impacts the eyes. Clinically, you'll see blepharitis, which is eyelid inflammation, and keratitis, which is inflammation of the cornea itself. Just look at the intense bilateral erythema here when those lower lids are pulled down. You can literally see the severe sloughing and blistering of the mucous membranes. It's a pretty harsh reminder of how deeply interconnected our systemic immune responses are with localized ocular anatomy.
Moving right along to Section 2, Ear and Sinus Pathogens.
We're moving down the skull to the ear now. This is a fascinating environment of two extremes. The external canal has your typical skin flora, but those deeper internal chambers, they require absolute sterility. Notice how the tympanic membrane, the eardrum, acts like a literal physical wall keeping external invaders out. Because of this barrier, pathogens usually have to sneak into the sterile middle ear through the back door, traveling up from the throat straight through the eustachian tube.
And when bacteria like Streptococcus pneumoniae actually make that climb, you get otitis media. It's an intense middle ear infection where pus pools right behind the eardrum, causing massive pressure, severe pain, and fever. So why are kids always getting this? Well, it boils down to pure anatomy. A young child's eustachian tube has a very flat 10-degree slope compared to a 35-degree angle in adults. That flat slope just lets pus and bacteria easily pool up and block drainage, basically turning the middle ear into a bacterial incubator.
All right, on to Section 3, Upper Respiratory Tract Diseases.
Unlike the sterile deep tissue of the ear we just looked at, this area is basically a bustling microscopic city. Friendly resident microflora are constantly battling dangerous opportunistic pathogens for space and resources. As we move down past the nasopharynx and oropharynx, keep in mind that this continuous mucosal lining is prime real estate for inhaled airborne droplets. Let's look at a couple of distinct bacterial invaders that specifically target the throat and larynx.
As future healthcare pros, you absolutely have to nail the clinical distinction between these two severe throat infections. Streptococcal pharyngitis, or strep throat, comes from Streptococcus pyogenes and classically presents with a fever and those very distinct white patches on the tonsils. Contrast that with diphtheria, caused by Corynebacterium diphtheriae. Diphtheria produces this terrifying, grayish, necrotic pseudomembrane that can literally obstruct the patient's airway, along with severely swollen lymph nodes that give a classic bull neck appearance.
See that intense red inflammation and those stark white patches of bacteria and immune cells? If you miss this and it goes untreated, S. pyogenes doesn't just hang out in the throat. It can travel up to the middle ear, or, much worse, it can trigger severe secondary autoimmune complications like rheumatic fever, which can cause permanent, lifelong damage to the patient's heart valves.
Moving a bit further down to the trachea, we run into Bordetella pertussis, the culprit behind whooping cough. What's wild about this clinical presentation is how strictly it progresses through 3 defined stages. It kicks off in the catarrhal stage with deceptive, mild cold-like symptoms, but then it escalates into the paroxysmal stage. This is defined by violent, breath-gasping coughing attacks that are so severe they can literally break a patient's ribs or cause hernias. Eventually, they slowly recover in the convalescent stage.
Next up, Section 4, Viral and Fungal Invaders.
We are transitioning deeper into the respiratory system now to explore non-bacterial threats. Influenza is your classic airborne viral pathogen. It famously thrives during the cold winter months, not necessarily because it loves the cold, but because we all huddle indoors, giving the virus the perfect opportunity to hop from host to host via aerosol droplets. And unfortunately, it notoriously preys on the immunosuppressed, the elderly, or anybody with underlying pulmonary issues. Now check out this CT scan. Look at that insane snowstorm pattern scattered across the lungs. That is not a virus, and it's not bacterial. That is histoplasmosis, a fungal infection. The spores of Histoplasma capsulatum get inhaled deep into the lungs. The truly insidious part about this pathogen, it actually thrives right inside the patient's own alveolar macrophages. It closely mimics tuberculosis, leaving these widespread calcified lesions all over the pulmonary tissue.
Finally, Section 5, the spectrum of pneumonia. We've finally reached the deepest, most critical, and traditionally sterile destination on our anatomical tour, the alveoli of the lungs. This delicate gas exchange tissue is the main battleground for pneumonias. And keep in mind, pneumonia isn't just one single disease. It's a broad umbrella term for an acute infection of the lung tissues and alveolar spaces. When pathogens like Streptococcus pneumonia trigger an inflammatory response, the microscopic air spaces literally fill with fluid. Clinically, you see labored breathing, and when a doctor taps on the patient's chest, it sounds dull and solid instead of nice and hollow.
And the spectrum of this disease is absolutely vast. On one end, you have Mycoplasma pneumonia, a mild organism lacking a rigid cell wall that causes what we call walking pneumonia. These patients are often young and actually stay pretty active despite being infected. But on the exact opposite extreme, the deadly Klebsiella pneumonia. This pathogen aggressively targets people with comorbidities, literally destroying the lung tissue itself, causing abscesses and producing a highly distinct, dark red, blood-tinged sputum that clinicians describe as currant jelly. Take a look at this AP chest X-ray. This reveals the devastating end-stage reality of those really aggressive pneumonias. You're looking at a fibrothorax caused by a previous empyema. Empyema is this horrible condition where thick, infected pus actually surrounds the lung inside the pleural cavity. The irritation is so intense that the body is forced to lay down rigid scar tissue, permanently restricting the lung's ability to even expand.
Okay, let's bring all these clinical presentations back to reality for a second. Imagine Jo. She's a surgical technologist. She wakes up with a cough, a little trouble breathing, and a red eye. Her hospital is totally short-staffed today. Should she go to work? No way. Based on what we've mapped out today, from highly contagious viral conjunctivitis to aerosolized respiratory bugs, recognizing these symptoms carries massive real-world weight. Going to work could easily transmit these incredibly resilient pathogens to highly vulnerable immunocompromised patients on the surgical table.
So, I'll leave you with this. These pathogens completely rely on us to do the traveling for them. Masks, vaccines, strict hand hygiene, and simply staying home when you're symptomatic are our best defenses. So as biology students and future healthcare professionals, how are you going to use the clinical knowledge from today's explainer to actually break that chain of transmission in your own future practice? Something to think about. Keep learning, and I'll catch you in the next one.